hypertension. Tissue diagnosis, as I explained earlier, was not obtained given the clinical urgency to commence therapy and the subsequent effect on results of the higher risk of procedure, including the tamponade. So the IV methylprednisolone was started, followed by oral prednisolone and rituximab to modulate the immune to decrease necrosis myocardium. And plus of that, she was on the 4 pillars of heart failure. 6 months later, this lady had a repeat. You can see here, this is pre-treatment, and this is post-treatment. I don't know if it's so much, but you can see that the fibrosis and the T1 mapping has improved compared to what it was before. This lady is clinically improved a lot. She's been seeing lately very, very regularly down in Dublin with the rheumatology team for Anderson syndrome, and down in Mayo in Castlebar with the heart support clinic and heart failure nurses. And literally, I think 2 weeks ago, the consultant, Dr. Brian Kerr, just texted me that she's doing great. She has improved a lot, and she's still on the modulators, sorry, and that this is definitely most probably, like, even right now with her EF is improving. Seems that this was most probably myocarditis, secondary to syndrome. So she had rehabilitation to improve the mobility. She's following up very regular in the heart failure clinic. As I explained, just that their terrible imaging, the cardiac MRI, there's improvement in the LV function and the RV function, improvement in the T1 mapping, and from the figure that we said earlier, which was 110 to 957. And even a transthoracic echo showed an improvement in EF up to 45 to 50%, which all of this together aim towards that this lady has improved a lot with Anderson's syndrome. And so the learning points of this case is that this case emphasizes the need for heightened clinical awareness of autoimmune myocarditis and Anderson's syndrome as a potential cause of heart failure. Early recognition along with immunosuppressant treatment is paramount for improving patient outcomes. This case highlights the critical role of multidisciplinary collaboration in managing such complex cases. As we know, we as cardiology, we try to have a tunnel vision about stuff, though it's good to have other specialties involved so they can help us in developing an approach for these kind of complex cases and even help in managing these cases. Patient journey can be challenging and may require multiple hospital transfers. Unfortunately, this is the reality we live here in Ireland. If you're working in a level 3 hospital, is that patients will have to be moved around until you try to get a diagnosis as soon as possible. Thank you very much. I think that's the end of this presentation now.
Thanks, Mohamed. Strong work. First, I would like to thank the SDUI and the academic office for creating this fantastic activity. And it's really an opportunity for all of us to learn from each other and share our experiences. Back to your case, Mohamed, just the first cardiac MRI, how many days after the event was done? Was it like straight away, or it took a week?
No, it did take a couple of weeks. Yeah, it did take a couple of weeks.
Yeah, like working in the cath lab, one of the things, like when we receive a patient with high troponin and query non-STEMI, so she fulfilled the criteria of MINOCA, which is myocardial infarction with non-obstructive coronary arteries. So it's an umbrella of diagnosis. It's include coronary causes like spasm or like rupture plaque, and it's just the vessel recanalized, or non-coronaries like myocarditis or stress cardiomyopathy. And as you've done the gold standard test after that, if we couldn't find any blockage in the coronaries, is to do the cardiac MRI, and it will give you the answer whether it's myocarditis or it's a transient infarction or something infiltrative to the myocardium. And I think that what you found, but we can't. Did she had any like previous echo before this event?
Yes, she
Because
actually did.
she had a breast cancer and she was treated with most probably chemotherapy, and most of there's the old generation chemotherapy that they can be cardiotoxic. So she had no LV dysfunction beforehand at all.
Yeah, that's the thing. Yeah. So 2023, she had a recent enough echo, I think a year or two before that. And her EF was preserved. There was no, there was, it wasn't reduced at any stage.
Yeah, because the recovery, the two MRI, the interval is 6 months, right? Because it's
Yes.
feel like the stress cardiomyopathy is, as you know, this reversible in more than 65%, and it reverses back in 3 months with the pillar medication. And she is on the pillar medication and plus the immunosuppressant. So the real gold standard test was the biopsy, differentiate between the two. But unfortunately was not done because the anticoagulation was on board and they didn't want to
Exactly.
interrupt it.
Yeah. So the as you pointed there, the gold standard is a biopsy to
Yeah,
actually
but like
say.
even the MRI, I think with the
However,
infiltration and
yeah,
fibrosis, it's very unlikely to happen in the stress cardiomyopathy.
exactly.
Yeah,
That's what
yeah, they
gave it
depend
away is that if there's
on
any
the cardiac
fibrosis,
MRI.
the fibrosis in the cardiac MRI went against being a stress cardiomyopathy is the reason.
Yeah.
Thank you very
So
much.
Um,
Yeah.
okay, Mohammed, that was actually a great presentation, to be honest. Apologies for the
Yeah.
beginning. Obviously, Mohammed, I didn't know you moved to Sligo. And
No, that's
for
fine.
Dr. Ibrahim, sorry, he's actually an interventional cardiologist. That's just for everyone also watching us on Facebook on the other side who came late. Just a quick question, if you don't mind me asking. When you put her medications in the beginning, you
Yeah.
had one of her medications, I think, was mycophenolic acid. That's an
Yeah.
immunosuppressant. I think you
Yeah.
used for Crohn's or something. Was this done previously or after this episode?
No, she's already on these. So that's Cellcept, that's the mycophenolate. So it's for her antisynthetase syndrome. So she's already known case of antisynthetase syndrome. It wasn't us being smart and diagnosing it. She's already known of the syndrome from before and followed up with the rheumatology team already. But this time she came with an acute presentation of an acute limb ischemia rather than
Okay,
anything else. And that
understood.
just kind of spiraled to heart failure
Fair
and
enough.
other problems. Yeah.
Okay, excellent. I think we may have a question from one of our audience. If anyone has a question, they
Yeah.
can just type it up in the comments. Might be faster. Hold on a second. Let me just check. I think one of our colleagues, Dua, here. I think she may have a question. See if you can unmute yourself. You can just ask away.
Hi. Assalamu alaikum. Thank you. I'm asking about the cardiac image. Why we go ahead just for MRI? We didn't go for CT coronary angiogram because troponin is high. And if there is any ischemia, so the gold standard,
she had coronary angiogram, Adra. She had invasive coronary angiogram and it showed clear coronaries. That's why the ischemia was ruled out.
Okay.
And just to add on, it's actually the MRI that's more diagnostic than a CT.
Yeah, for the muscle.
For the muscles. Yeah,
Mm.
so you want to look at the muscles and if there's any fibrosis around the muscles, that wouldn't be shown efficiently in a CT coronary. CT coronary is just looking, it's an angiogram, but it's just looking at the arteries rather than the whole muscle of the heart.
And the muscle of the heart is shown by the echo. There is reduced ejection fraction and there is fibrotic case by echo or So
You know
what is
that
the
the
echo?
fibrosis is only in the MRI.
Yeah,
The
but what is the echo finding? Indicates that she has
just the reduced TF. So the echo didn't show us anything. The just shows us the ejection. So you
the
want to know
diastolic dysfunction
action?
or
Yeah. So there was by ventricular dysfunction.
Systolic.
Systolic dysfunction shows us the systolic dysfunction. It shows you if there's any valvular lesion or if there's any thrombus, and how is if there's any dyskinesia or akinesia. So that means just the movement of the muscle if it's moving or not.
So
It's
the
just
echo, Muhammad, also it the first echo it's helpful differentiating between the stress cardiomyopathy and the myocarditis. You can see here in the stress cardiomyopathy, it will be like apical ballooning shape. So the apex will be akinetic and the base of the heart contracting well. When you see her echo, she had global hypokinesia, which is something involve the whole myocardium.
Mm-hmm. Yeah, okay.
Let's try to open it here just so people will remember.
Meanwhile,
Dr.
if anyone
Rodriguez.
else has any questions, you can type it up by the time he pulls up the image.
Thank you.
So yeah, I think Dr. Talal just explained that it's just you can see the squeezing around the heart is very impaired, and there's no actual obvious ballooning that you can see in Takotsubo. And yes, I should have just said that also that stress cardiomyopathy is also Takotsubo, broken heart syndrome, but it's under an umbrella of stress cardiomyopathy.
Okay.
See if there's any questions.
All right, let's just have a look and see. I don't think there's any other questions.
I have a question, please.
Yeah.
Oh, yeah.
Hi, Mohammed. Thanks for the case. Thanks, Dr. Talal. Great case, great presentation. I just have one question. Is the two questions actually. The pulmonary hypertension, was it a pre-existing medical condition for the patient that she's having interstitial lung disease, or is it something secondary to the acute left-sided heart failure? It looks like a pre-existing because it's pre-capillary, I think you said in the right heart cath.
It's exactly correct, Talal. Very, very, very excellent question. Yes. So why we did the right heart cath is to see how bad is her actual pulmonary hypertension. Is it also contributing to her having so you know that you can have mixed disease, pre-capillary and post-capillary. And here you can see it was mostly pre-capillary. So this is mostly pulmonary hypertension. And the figures in the right heart cath was not that high to suggest that it was
I think the
severe
mean
pulmonary
was 27 or something,
Yeah.
which is just mild pulmonary hypertension.
Yeah. So it just helped us out so to see if she does have significant pulmonary hypertension going forward with or a mixed pre-capillary. But you correctly pointed out it seems like it's a long-standing pulmonary
pre-existing
hypertension exactly from her. So
pulmonary
her
hypertension.
background exactly her background is antisynthetase, and antisynthetase is one of the things that it causes interstitial lung disease. So interstitial lung disease is a known cause of pulmonary hypertension.
And her wedges 14 is like just the higher normal. So I think it's just that pre-existing thing.
Okay, yeah, and also I have a second question. So to sum up, this lady, she came with acute decompensated heart failure, ejection fraction of 20%. She was medicated with the 4 pillars, ejection fraction built up to 50%. So now we have heart failure with improved ejection fraction.
Exactly.
So the big question is, what happened with the 4 pillars? What did you guys do for the beta
Well,
blockers, MRA?
we continued on them. We continued on them. I
All the
know there is.
recommendation to
I
continue.
think there is no clear-cut guidelines for continuing these things in the setting of improved, is it?
Well,
No, I think it's a consensus. Most of the heart failure consultant, even with like young people who had like a myocarditis and they got severe LV dysfunction and the LV improved, at least they keep the ACE inhibitor on board. They won't take it off
Yeah.
totally.
So as you correctly pointed out, Awad, again, is that there's no consensus in the guidelines saying what to do if you have a reduced heart failure that has improved. So it's kind of a case-to-case basis. They would suggest to continue, if I remember correctly in the guidelines, the advice is there's no clear advice of stop or not to stop, but they would lean towards continuing the medications. However, some consultants, and you've probably also seen that some consultants take off, as Dr. Talal said, take off a couple of medication and leave couple. In her case, we continued in all of them, and the improvement of the heart failure is actually, the question was, it's not like, in fairness, 4 pillars will improve your heart failure. That's scientifically known, but it's improved after. So to explain to everybody that the cardiac MRI was done, and that showed impaired systolic function, and that was 3 weeks or 3 weeks after her event. The methylprednisolone was started 2 days after that cardiac MRI. The right heart cath was 4 days after the initiation of the steroids. So from a ventricular systolic function in 2 weeks to improve to 26 to near normal, well, the only reason explainable is that the steroid has helped. It was all of the steroids rather than the 4 pillars, because she was already on the 4 pillars when she had the cardiac MRI. So this it's just a question of course, we're going to continue on the immunomodulators. The question is, should we stop one of the 4 pillars? That's it's a kind of
it's a dilemma, really. Yeah. But thanks.
Yeah.
I just really have one last question if you have time, guys.
Yeah, of course.
I think yourself and Dr. Talal, you have said lots of things favoring stress or favoring anti-synthetase related cardiomyopathy instead of stress cardiomyopathy. But also, did you guys check the antibody level or any kind of anti-synthetase related serological or biochemical things, to say this is a surge of autoimmune disease instead of anything else?
Well,
from before.
Yeah.
No,
exactly.
I mean now in this acute event.
So you don't. What I understand from anti-synthetase is you don't have to get an anti-Jo.
Okay.
To find out if there's.
The
I know what you mean
markers,
is like.
You mean
Biological markers, like and sometimes I think in autoimmune, I'm not too sure of an SLE. I think you check for the ESR rather than the CRP, or you check the autoantibodies. But that wasn't the case. It's more of the autoimmune. And also, sorry, just to point out why we thought it's more of a clinical diagnosis right now, because she had this event, the thromboembolic event, and that's also a complication of the anti-synthetase syndrome.
Okay. So that means the disease was active.
Yes, exactly, and that explains that that disease was more active rather than it was in a dormant phase.
Okay, thanks a lot. Thanks for your time.
Okay, thank you.
All right, that's great. Okay then. So I don't see any more questions here. So Dr. Ibrahim, thank you very much for giving us the honor of your presence. Mohamed, that was an excellent presentation. Thank you very much for the presentation today. And we will see you guys next month.
Thank you very much.
Thank you. Last, if we can say that I would like to invite all the junior doctors in different specialty to share their cases, and the academic office will be more than happy to facilitate the presentation.
Absolutely. We're always happy for any junior doctors to present their cases, and we're more than happy to facilitate and give them a slot. It helps all the specialties share their experiences with one another. Thank you very much, Dr. Ibrahim, for that.
Thank you for the opportunity. Thank you, everyone.
Thank you, Mohamed. Thanks.
All right.
Thanks, everyone. Have a good weekend. Thank you. Bye-bye.